where we all are in the country. In fact, I tried to do a little map of where all of our community practice leaders are through AI, but it obviously doesn't know its geography because London's at the top and welcome everybody. Okay, so I think we've got enough people in the house to get going. Nick, do you want to pop the slides up if that's all right? Thank you very much. So welcome everybody to our, actually I don't know which webinar we're on now, quite a lot, maybe 19, something like that. I'm Nicola Verstralen. I'm the sort of leader of the community practice. And the next slide, we will show you who the rest of our group are. It's a growing group. And I'm not going to go through everybody's names, but you might recognize some people in there. So this is our community of practice that are behind the group steering the webinars. Next slide. So today's webinar is it's going to be a really thrilling, interesting one. We've got two speakers. Silas is going to be talking about evidence-based practice and deep diving into the practicalities of what that means to nurse managers. And then we're going to hear from Philippa Olive, who's going to talk to you about an opportunity for leaders to get involved in supporting their development around the toolkit and online development. So we're going to start off with Sals, I think. Just go on to the next slide. Is that the first slide I've got? Oh, just one more slide before we start. Just to remind everybody, this is the sections that are in the Matrons and Health and Care Leaders Toolkit, and our sessions today fulfill all of the topics, all of the different sections of the toolkit. Next slide. And I'm going to hand over to Silas now. Silas, are you there?
Yes, I am. I
Welcome.
hope
Go
you
for it.
can all hear me.
Yes.
Right. Yeah, so I'm Silas Sagridian, PhD candidate in HO University. And as well, I teach on the Master's in Nursing program, basically around leadership, change management, evidence-based practice. And so I'm happy to share some of my knowledge and insights around the topic today. I want to add that I'm also a nurse, having practiced for about 15 years, I think. And I've also served in the role as a nurse manager before moving into the classroom uh, as the lecturer. So um, these insights and this study topic, it means a lot to me because I think that most times evidence-based practice at the hospital can be a bit overwhelming, especially for leaders. And so it's important that we talk about it. However, it is also important to note that evidence-based practice is the only way by which we can move research evidence into practice and make patient care better. So without wasting much time with introductions, can we move to the next slide, please? So we're going to consider briefly what evidence-based practice is. I'm not going to pretend that by this 20 minutes we will be able to understand fully, but at least I hope that by the end of this, we will have something moving us to be able to gear towards that goal of carrying out evidence-based practice. And I'll also highlight some of the challenges, insights that I've gathered so far as part of my studies and how we can move forward with evidence-based practice as nurse managers. Next slide. So if you are aware of evidence-based practice, this is a popular definition that is fostered by Sackett. And he says evidence-based practice is the conscious, explicit, and judicious use of current best evidence in making decisions about the care of individuals. And those who are aware, you would know that this definition came out from the medical field and so has largely, as a developing concept, migrated into nursing. And we have also tweaked it a bit to be able to serve our purpose as nurses. And so when we look at the definition, it it's about taking the best evidence and using it to inform the care of our patients. So I highlight the words individual patients because the purpose of it is to ensure patient-centered care. And we are using the best evidence that is available for that. This definition has expanded as we move forward, and you will get to see why. And so currently, if we can move to the, let's press the button a bit. Currently, in evidence-based practice, within nursing, this is the definition that we're going with, or that is more popular. That is the thoughtful integration of the best research evidence, nursing expertise, and patient needs and preferences to guide care decisions in the context of the practice environment. So, when we consider evidence based practice, it is not just taking research evidence per se, but we're looking at the very best research evidence. So, we keep on discovering new things. And as new things are being discovered, we have to sometimes let go the old things. So evidence, for instance, will support the fact that when you tepid sponge a person, the temperature will come down. But a later evidence comes to show that when you do warm baths, it will even come down faster. So we improve on our knowledge as we go. And in the context of patient care, we use our expertise and what the patient's needs are in driving the care. So in this example, you want to bring a patient's temperature down. The patient says, I don't like cold water. You do know that the evidence says warm water will be able to bring down the temperature. So based on the needs and preferences of the patient, you know that when you use the warm bathing, the temperature will come down because evidence supports it. You adapt to that. Whereas in another context, the patient may say, no, no, I don't like warm baths. I prefer a tepid or cold bath. You know that the evidence supports this as well, that it can bring down the temperature. So we use evidence thoughtfully and we integrate that with the existing evidence around us, what you know at the practice field. You see, so for instance, as managers, I'm looking at the context here. You intend to therapist point the patient, but you don't have gadgets for warm water. As somebody like me coming from a developing country, most times you wouldn't be able to get warm water in the hospitals or something like that. So the context of your practice might influence how you are going to use the evidence that is available. And that is why evidence-based practice is an integration of not just the research evidence, but that of your expertise. That's what you know about your hospital, the ward, the strengths and weaknesses, and all of that, that context knowledge, that expertise. You will marry that with the evidence as well as the needs of the patient and their preferences. And when we put all of this together, then we can be saying we are carrying out what is called evidence-based practice. So we please press on. So when you look at the two definitions, it's been expanded in that you are not just using just the current evidence in making the care decisions for that individual patient. Yes, that is there, but also you have to look at the feasibility of doing that, how possible, and what is the very best way that I can carry this evidence through. And I want to give another example and then we can move on. In Aldahi, there was the evidence of conditioning children with lighting within the ward to be able to let them relax and rest. However, it was difficult implementing it across the whole ward. And so by interaction with the children and all of that, the children said, no, instead of doing this for everybody in the ward, we can change that using glasses that can condition it for me as an individual and not be that expensive and the rest of it. And so, yes, the evidence says this conditioning, lighting, the colors, and all of that will have an impact. Carrying it and implementing it is another thing. And that is why nurse managers have to be involved in this to be able to get it going down to practice. And it also means that you must factor in the context of the practice environment when you are making these decisions. Next slide. So, in evidence based practice, you would assess your environment and then determine what is what does needs change in my place. And as nurses and nurse managers, you work all the time, you gather data all the time, you have audit reports and all of that. So by your practice, you will know best within my area. Maybe patients have complained, they are not very satisfied. What is the problem? Audit has ID certain problems that are challenges for you within your unit. Based on those things, we develop clinical or evidence-based questions. How can we address this thing? What is the best way to do that? And then by asking the question, we look for the evidence by acquiring them and then appraise the evidence in light of the type of study. Most times, uh, depending on the type of question that you are asking, and there are various types of questions which I won't pretend to go through all of them, maybe a diagnosis question or even a management question. That would dictate the type of evidence that you can rely on. So for instance, if it's a question, the most strongest evidence you would want to rely on, if it is available, is a randomized control trial. If you want to see, is paracetamol better in controlling the pain of these my kind of patients within this age range post-op as against NSAIDs or any other drug? Your best bet is to look at a control trial. But if you are looking at, will nursing load be able to help me to reduce the number of falls that we're having or the infection rates within my unit, that question would not necessarily be answered by a randomized control trial. And so you will, can you hear me?
Yep, yep.
Right. So in carrying out evidence-based practice, the kind of question or the type of question we're asking will dictate the type of evidence we'll be looking at. And then we'll have to acquire them. Then we appraise the evidence. Has the evidence that I've gotten, was the study done in the context of a similar context of like mine? The people that are in the study, was it for children or was it for adults? The ones I am dealing with, are they comparable? So once you appraise the evidence and you realize, oh, I think they are similar, then I can take this evidence forward. Then the next bit is to apply. And the application stage is in itself another difficulty that we must cross. And so in my study, as we go forward, we'll see why this part can be a little bit tricky. So we then bring in the evidence onto the field. And after implementing it again, we assess to check whether the change has brought us the desired output that we're looking for. Next slide. So research evidence takes about 15 years to get into nursing practice on average. So if you are working, for instance, within the orthopedic care, you realize that we say use spirits on wounds or surgical wounds. We don't use spirit directly on surgical wounds if we want it to heal by first intention. And yet it is something that is commonplace, despite the evidence that has been in existence for years. And why is that so? And I think leadership matters in this case because there is no way practice is going to change in anybody's unit without the consent of the leader, without the support of the leader. And so it is my argument that in order to break this 15-year gap, we will need nurse managers or nurse leaders on board to force research evidence getting into practice. And I believe it's the best bridge. I'm saying this because in my when I became a leader, I was um, I was not trained as in any of these. I was even trained in leadership. I was just picked as the senior staff around to be a leader. And when I assumed that position, I was able to get certain changes done much more faster, which I could not get done at the time that I was a leader. I would tell my manager, and she said, no, this cannot be done. This is not possible. However, when I took over, I was able to get all those things that she said was not going to be possible done. And so leadership is, for me, the biggest thing in driving research at the practice field. No matter how equipped and knowledgeable your staff will be, research evidence cannot be moved forward without the support of the manager or the nurse leaders, especially those in formal positions. And if we are unable to do that, if we can press on the key, it means that we will not be using research evidence or facilitating its use. And that will lead to harm, would prevent patients from receiving the full benefit of medical advances and science and research that we have been able to do. And it also creates unnecessary expenditures if some things go wrong. For instance, you can land in a suit in the for the hospital that will cost them a lot if you are not using the best practice and you are sued. But if we're able to do that, it means that, please can you press on next? Yep. We will be able to achieve these benefits, improving the care and outcomes for our patients, and also make nurses feel good because there are a lot of nurses who are not satisfied with their role simply because they feel they are shortchanged in giving their best to patients. And that frustration will really go away if we nurses, leaders, or managers are able to allow them to bring the best that they have to underline or provide care for the patients that we serve. Next slide. So my investigation unearths a number of challenges why research evidence is not getting to practice. If you scan the QR code there, you should be able to read the full article to understand. And when I encountered the study, I realized that these factors that are given here were in multiple studies across the world as things that allow for research evidence to get to practice. So things like good knowledge of evidence-based practice, having positive attitudes towards it, or believing that I can do it. That part is very essential for evidence to get to the field. Also, if they have access to organizational resources as I've listed there, and meaningful policies that support all of that, evidence is able to usually foster. or get to practice. If you can go to press next key. But it's interesting to know that the barriers that are found in literature were almost identical to the enablers that are found. And so this made me again, what is happening here? The same thing that can facilitate research getting into practice are the very same things that are stopping it or seem to be stopping it. But there's something more interesting which I discovered in that in the studies that are analyzed, wherever evidence base was able to have its way, all these factorizational domain that are barriers were present in the same context where the same barriers were present. Evidence-based practice was able to happen when one of these two factors of the enablers are present. So where you have good knowledge of evidence-based practice or competency in it, and you had a positive attitude and belief towards evidence-based practice, it doesn't matter the level of problems or barriers within the organizational factor, evidence-based practice was able to have its way. That was quite telling for me. It means that managers that knew how to carry it out and also were enthusiastic in doing it were able to get it done. Whereas if you just had a good attitude for it and you didn't know how to carry it out, you were not able to do anything. More so, if you knew how to do it and there is no passion and zeal towards it, you could not also be able to carry it out, or there was no progress in evidence getting to practice. So this is very important for us to consider as managers. Do I have knowledge in this? And am I willing to support? Do I believe I can do it? Next slide. So this is just a summary of what I have just said. Personal factors are the key, most decisive factors in successful implementation. That is your knowledge and your attitude. When these are lacking, no matter what we do, evidence cannot just make a move. The barriers within carrying out evidence-based practice are complex and interdependent as well. So yes, I acknowledge that these are the most decisive factors, which are the personal factors, but this is complex because if you know how and you have the positive attitude and the environment doesn't support you, that can, though you might be able to advocate, takes longer. But when the environment is all conducive and you know how to do it, you are positive about it, that will just get things running so fast. Next slide. So this was the rest, what I've just mentioned already, from literature across the world. But these themes I'm going to look at, I looked at what are the enablers and barriers within Alder Hayes specific. So I interviewed nurse managers to try and determine the local and context problems and enablers that I could find, because there were only two studies that I found globally that were, um, you know, that were within the four studies that I got. So it was important to still probe it further within the UK context. Next slide. And these were major themes that I found around the topic. In terms of evidence getting to practice, I realized that there were understanding and confidence gaps. Most managers I interviewed did not really understand fully what evidence-based practice actually means. So they regarded evidence-based practice as important, which was great.
Absolutely. I'm going to read Helen's document now.
Could you pop on silent, whoever's talking, please. It's okay, I've done that.
So you realize that it was great, the people had great value for evidence-based practice, but there were fragmentation in terms of their understanding of what evidence-based practice really means. And they also had limited research skills and confidence, as well as difficulty in finding research evidence or information, yet they were very willing to learn. So if you look at some of the uh, citations I put up there, you realize this, which is interesting. So one said that I think it's important we practice evidence-based practice we do it on a daily basis. And one said we follow guidelines and policies. That's evidence-based practice, isn't it? And so it's great if guidelines are evidence-based guidelines. They would not necessarily be evidence-based practice if there is no evidence backing the guidelines. And then another said, I don't feel it is us going out hunting for the evidence. But yes, we are the ones to look for the evidence because we have the problems to solve and we have to find out how can we best solve this problem. Next slide. Someone said, I probably wouldn't necessarily know what the evidence, what is evidence-based and what is just good practice and what is just what we do. So, and these are, if you look at how I've named them, 8 means this is a band 8 person. A 7 code means the person is a band 7, right? So these are senior members of our managers that have these challenges. So it tells me that evidence going into practice would have serious challenges in these cases if we don't know what we are doing, which of them is actually evidence-based, and if a thing is not evidence-based, that is a bit of a problem and a challenge that we managers have to get to develop ourselves better to be able to get evidence going into practice. So someone says, I let the clever people do it. You know, we have to be the ones leading the charge because a manager or a leader, you are the one to create the vision. You are the one who know the context very well, and you are the one responsible for your unit. So you should be leading. And it's great sometimes to have people support you. You have the teams, but the charge should be you driving that. You assigning people and making people responsible. You, what? Uh, Delegating some of your authority to others to be able to fight this or move this forward. Next slide. I also realized that most of the managers taken from what I've just said were leading from the back instead of from the front, you know, and that they saw that their authority was constrained. A manager said that it's more given to us what is already researched. Usually it comes trust-wide. I don't feel that it has going out hunting for the evidence. We wouldn't change something that might affect patient care. That is true. But the change cannot happen without changing the things. And most of the things as we do are low value. If there were no research backing them, they were just traditions. For instance, evidence has come to show that too much use of gloves leads to more, hospital-acquired infections. So every procedure shouldn't be wearing gloves. It is we, the managers, who will determine, okay, so let's look at our workplace. What are the things that we do? Which of them do we have to reduce the use of gloves? Which of them can we keep doing so that we are not abusing it and leading to more hospital-acquired infections. So yes, we have to change the things, but they felt constrained that they cannot make some changes. They were so reliant on others telling them what should be done instead of finding innovative ways to drive forward things. It is great also to note that they had quality teams and specialists in that hospital. And for me, that was one of the biggest strengths that they had that was able to, as an enabler, driving change in the practice field. But following rules and procedures necessarily does not mean evidence-based practice. Following guidelines that are not evidence-based is not evidence-based practice. So we have to take note of that. Next slide. Staff attitude and workplace culture was one of the most interesting one for me. They were very open to change. That culture within Alda Hey, really, I think it's something that if you're able to have around you, it's just great to be able to drive evidence-based practice and to be able to foster change. The people were very open to learn, you know, though there were some limited recognition for good work done. As managers, we should encourage staff that are around us that are doing well and pushing these boundaries for us, fostering research within the place and all of that. And when people do things and do it well, you should say, hey, you've done well. That appreciation goes a long way. There was also uh, learning through practice, which I found very interesting. People who involved in research are more likely to engage in evidence-based practice, and they learn a lot of stuff by that engagement, by the mere fact that you are just part of the process. Whether you're recruiting patients or something, that process teaches you a lot, and it also enhances your capacity to be able to carry out evidence-based practice, which is a good thing for ALDA, and that we can also adapt in our various places. If you want to foster research culture, you should create the environment to allow people to question it. You should also allow the environment for learning from research and through practice. Yep. Next slide. There were system barriers such as not enough time to do it. I think I moved this forward when I went to meet the stakeholders to discuss the findings. And some people did not agree that there was not enough time because managers are given time to decide what to do with it. And so they found it a challenge that people still said there was no time. But I realized upon further uh, reflection on these issues that when we don't know what something is, for instance, some people consider evidence-based practice to be research, which they are not researchers. So if you think it is a research process, that will have to go looking all the way through the process, searching for evidence and do all of that. When we see and picture it like that, then we would think there is no time for us to engage. So it is important that we really understand what evidence-based practice is and how we can move it forward. So time was said to be a challenge, but that some say it is not really a challenge, it is something else. Maybe we can think about it as managers and reflect to see, is time really a barrier? Budget restraints and all of that. And all of these barriers that are there, for instance, missing research in some areas, we are the managers that have to encourage research within those areas. And we have to advocate for these things. If there are low budget and resources, we sit around the policy tables and decision tables. We have to advocate. But if we are not interested ourselves, then we will not be making those advocacies. We cannot be able to move it forward when we are not interested. We don't believe in it ourselves. We think it cannot be done. Somebody say it just cannot, is it takes about a year. No. Next slide, please. Um, Proving that change works. So it's interesting to know that within our Hay context, people who had taken research evidence and implemented and resulted in positive change within the practice environment were more seen to be able to drive it forward again and make business cases using those examples of or success stories, right? So they were able to say, oh, we did this and it worked. And so we want to, evidence is showing this. Can you support us to carry it forward? So they were able to drive further change based on what? The positive experiences they had already enjoyed. And I think that it makes positive sense if you can tell the people who will give you the money that we want to do this change. These are the benefits it's going to bring to us. We've done it before. We've gotten this kind of change. So can we move it forward? And I can say on authority that when when I was able to reduce infection rates within my facility, and I didn't do magical, I just simply saw that changing the bed sheets, not when they are dirty, but at certain periodic times, according to research, was the best way to reduce infection post-op, especially for my unit. So we're changing the sheets. We just uh, give a time every 2 days. We're changing your sheet, whether or not it is looking dirty, and the infection rates fell. So afterwards, anytime I was looking to do things, I had that favoring or favor from management in that they endorse most of the things. And so other managers were like, why is it that Silas goes and he gets it, and we want certain things and we're not getting? The reasons is we are using your stories and results that you've implemented from evidence and making the business cases, people will be able to buy the idea. So these were some things that were prevalent in Aldahay and that supported their change as well. Next slide. So one of the great things is that Aldahay had researchers that supported their movements. So they had that strong support. Also, they had educators and quality teams that also came in to support them. So if you look at it, I just said, if you delete, for instance, the researchers, the practice educators and QI, it would be very difficult for evidence to have gone into Adahi as it has so far, because these were their anchors. So if you are in a facility where you don't have researchers or QI teams or educators and staff, you have a more bigger hurdle if you, the managers, are not pushing yourself to drive the evidence. You may not be lucky. So you have to take that responsibility to ensure that you yourself you are equipped and you are charged toward you believe in yourself that you can do it and you can be able to get evidence going. Next slide, please. So I realized that band sevens express more technical needs. That is, they couldn't appraise research evidence. They don't know how to navigate, even if they have the evidence. And they viewed evidence-based practice as external to their role, which is never supposed to be so. Some actually also said that like the top management around band 8 and 8 plus, B plus, they were also like, I no longer do evidence-based practice. And I found that very interesting because evidence-based practice questions are not necessarily clinical questions. It borders around, let's say staffing issues. So what is the ratio of nurses to your patients that will better help you to carry out your mandate within the unit? That cannot be answered without evidence, without research. So those questions are not directly clinical, but they are things that you ask. So your assigning of staff to units and all of that must be informed by evidence. How you promote, what sort of promotions or incentives can we give out that can really bring that vibe within your space can be informed by research. How you lead and the way you go about it itself can be informed by research, emotional intelligence, and all of that. So you cannot decouple research within management even. So I think that there is a lot of training that has to go on around the technicalities of evidence-based practice. What is it really? How can I engage in it? And as I'm developing this intervention, which I really love the progress so far, you realize that the thinking of most people is that we have to start from assessment all the way through to application. But that is not the case. You don't need to necessarily go through that cycle every time. And so I will give this as example to end my presentation. If we have found an evidence that has been systematically reviewed within our, and is similar to our context within the last 10 years, that evidence exists. As a manager, when you get that evidence, you don't need to go around searching for evidence again. If it answers your practice question, you only need to look at how do we apply that evidence. So you would have checked the box that this question is what I'm trying to deal with in the practice environment. This evidence speaks directly to it. They are more similar. And therefore, I'm now looking at how do I apply. So we can skip most of the steps. We don't necessarily have to reinvent certain things in the application. And if we're able to see it in that context, you realize that it's as short and simpler than we think. Next slide, please. So managers in this facility were more committed to improving care, which is great. They were frustrated by the lack of time and resources, and they were uncertain about how to lead evidence-based practice in itself. But what I love most about their emotional landscape was they were hopeful and open to structured support. And the only way change can really come is when people are open to receiving it. And so I believe that the intervention as is being developed, when it's complete, will really be able to bring, solve most of these frustrations they have, and they will be able to engage effectively within evidence-based practice. Thank you. Next slide. Next slide, please. So comparing what is in the UK to what is elsewhere globally, I found that there were not much differences. They were very, very similar. But the details shifted a little bit. The problems of resources and how they surface within African context was completely different from the UK context. So whereas, for instance, Africans would not even have databases to search for the literature, the ones that were here didn't know how to navigate the databases and to even get the resources out of it. So we had similar challenges, but they appeared or presented a bit different. So that should tell us that it's important that when we want to bring change, we consider what are the factors around our context and situate whatever it is to your context, and is the best way to have evidence going. Next slide. Next slide. So it's important previous slide, please. It's important that we equip managers with a tailored evidence-based literacy support. And so the current intervention I'm developing is actually marrying the type of questions that can be asked to the role that a manager plays. So if you are a band 7 nurse, for instance, there are certain things that you are by necessity supposed to do by your role. And so there are obvious questions that you are expected to be asking. And so the type of questions that can be asked, I have linked all of that to the type of band. And then the training should be such that by the time you finish within your band, you have those competencies to be able to ask those specific questions pertaining to your role. And when you go higher, a managers, you would by necessity should have the senior manager should know all the lower ones. But what is most important is how to ask management questions. So it is tied to the role of the specific nurse manager or leader. And that kind of tailoring allows that they are able to see relevance of the learning and evidence-based practice to their specific role. And then they are able to execute it well and ask it well and know how to make the business case for it or drive the change in those respects. I also found that it's important that we reframe leadership around evidence-based practice. Nobody is going to bring research or improve nursing practice if we are not doing it ourselves as nurses and we don't support it. So managers must change how they see leading research and evidence-based practice as something that must come from somewhere. You have to lead that charge at your specific place that leading or heading. So we must own it. We must own it and trust in the process that once we are going it per research evidence, we can't be wrong. We shouldn't be scared that, oh, we can get it wrong. And no, as long as evidence is backing what you're doing in the context of the care, you should be fine. So, for instance, in scheduling staff, in my place, there are times that we have cholera and outbreaks, seasons. I know as a manager the seasons that we have. So when I'm putting staffs on duty, I know when to make them more and when to reduce them. I don't just go with nursing ratio um, blatantly, but I consider the specific context of the care and know when things will go up and when things will go down. And the same in the UK here, you will know when things would change and when things would be different. I don't know that very much because I'm still new in the UK. But if you work here for long in your context, you will have that expertise. You must bring that evidence and marry that with the research evidence and make a good decision. That is why we say evidence-based practice is an integration of the research evidence with other evidence, context evidence, your expertise as a manager. You know your staff, you know your capacity, you know the staff's specialties as well. So you bring all of that and know that, oh, this thing we can do it here or we cannot do. If we cannot do it now, what can we do later or in the interim so that in the future we can be able to carry it out? All of that are things that we as managers need to be leading. So we should not be seen to be taking the back seat and wanting someone to come and do it. We have to bring the charge. And the last thing I want to sit on is that in terms of policy, it is the managers that are most effective in policy making. You can influence the policies and address all the barriers that are within the organizational scope. If there are no resources, we have to make the case for that. You know, if there are no access to libraries, you have to fight for that and ensure that they are there. But I also realize one thing, that most times we are not aware of the resources that we have around us as managers. So it's important that this topic is discussed at a more elaborate forum where we can take each aspect of evidence-based practice to deal with. For instance, how do I assess? How do I make sense of the local data that I have, the audit reports and all of that, to use it to create an evidence-based question? That itself would take about a day to really have the practicalities of it. When it comes to applying evidence itself, how do I adapt change management tools and stuff like that to help me implement the change? Because something can be good, but if you don't follow the process, the right process to implement it, it may not be end well. And so all of these things are stuff that we managers have to think about and see how we can influence those and change barriers into enablers and bring research evidence to patients. And like I said, patients come to the hospital not for the building. All they want is to be relieved of their pain so that they can go home. And they come there believing that they are going to do that using the very best evidence and best approaches to give them that relief. They trust you completely. So let us not fail our patients. And let us make nursing great and strong and a proud profession. Thank you very
Thank you,
much.
Silas. Thank you so much for that. There's lots to reflect on there. Maybe we'll bring that back to another session, but I just need to bring Philippa in now for her something that we want to promote as an opportunity for many of our clinical leaders out there. So, Philippa, do you want to come in there?
Yeah, hi, good afternoon, everybody. I'm going to keep this really quick because we've only got 5 minutes. But I think that what I can do is I was going to talk about the online implementation program and the toolkit evaluation, but maybe I can come back and talk about the evaluation at a later meeting, which is, yeah, it's something that we're really excited about. But what I'm going to ask Nick to do is actually just to go to slide 8, if you can. And we'll just go next there, just stop there. So yeah, so we're launching an online research toolkit implementation program. It starts January the 13th. It's open to all health and care leaders in England, wherever you work. And Nicola and myself are facilitating it. And it's going to be 6 online workshops once a month from January to June. We're going to be kind of following the sections of the toolkit, but the first session is going to be around using the self-coaching and personal development planning that was developed with the toolkit as well. So it's very much about developing that armory of research leadership skills for the future. I'm obviously really mindful of time, so if you want to email me to find out more than happy for you to get in touch. There's a link in the slides here to the registration. We also have a flyer that we'll send out as well, because I have heard that a link I put in an email doesn't work, but I know that the flyer link works, and that flyer isn't live that's on the presentation because it's an image. But yeah, so we're really excited about this. We're developing it. We're introducing it locally, and we've had fantastic response from our advanced practitioners, clinical practitioners, nurse consultants, who are actively registering for it. Places are limited, but if there is a real demand for this, we'll run another series later in the year as well, probably starting in September through to February. So yeah, so if you could please, Nicola, I'm sure we'll send out the flyer. Please have a look at it. Please get in touch with me if you have any questions about it. But we think, you know, the benefits of a community of practice is people working together to develop those leadership skills, you know, is really advantageous. And so yes, I'm just going to stop there because I'm just really mindful of time. But if anyone has any questions about it, like I say, now or please get in touch. Thanks.
Thank you, Philippa. Yeah, so I will send out the flyer for it. And yeah, as Philippa said, it's a really good opportunity to think about how you might be able to speak to your peers about how you might develop that research culture around all the bits that are in the toolkit. So yes, we'll end today with a little Christmas picture as well. Thank you everybody for listening today to such a fascinating presentation of Silas's research. And obviously he's only part way through. He's got more to come, so I'm sure we'll be inviting him back another time for more episodes of his research. We are not going to be having a webinar in December. Last year we had a bit of a Christmas special, didn't we? But we are going to be putting out a Christmas song. We've got some music therapists in our team. And so, yeah, we're going with the music theme, and we're going to be talking about any diamond moments that we have had in our webinars, or things that we've learned, things that we've been able to take forward over the last year. So if anybody does have any diamond moments that they have taken away from any of our webinars over the last year, please do feel free to email us to say what those are, and they might be included in the song. So our next webinar is in January, the 27th of January, 2 till 3 p.m. And that is going to be on the sort tool. What now? So for those that you don't know what the sort tool is, it's an assessment of organisational research readiness to do research. And that is really where our toolkit fits in. So there'll be a lot more discussion around that at our next webinar. And then please do log on to or register for Philippa and I's bespoke sessions to help you take some of those things forward, because if you have done the sort tool and you've identified any gaps in your organisation, the toolkit and all of the things that we'll be talking about in these sessions will help give you ideas on how you can create your action plan and take things forward. So brilliant. Thank you very much for listening. And dead on 3 o'clock, we will wish everybody a lovely Christmas, and hopefully everybody will have some nice time off with their families. And we will see you in the new year. Thank you, everybody. Thank you, Silas. Thank you, Philippa, for talking. And we'll see you next year.
Thank you. Bye.
Thanks. Bye-bye.
You're all right, Claire.
Yep, just waiting to see if everyone's gone. They have
Yeah.
gone, I think. Are you all right?
Yeah, good, thank you. We missed you yesterday
I
at the
know.
SRL. What a shame.
We're still recording, so yeah, I'll fill you in.
Yeah, bless you.
Yeah.
Oh well,
Did it go
let you know.
well?
It did. It was very good to see everyone's work. But hopefully it will, well, it was recorded, so hopefully you can have a glance at it. Yeah, it's very good.
Lovely. That'd be great. Thank you. I'll catch
Right.
up with you soon. Hi,
Yeah.
Anthony.
Hi, Claire. Good to see you.
And you. Yeah,
Yeah.
we're still on record, so we'll catch
Okay.
up. We'll
Okay.
catch up.
Bye.
We'll all catch up later. Nice to
All
see you.
right.
Have a good
Bye.
weekend.
Bye.
Bye.